Hello everyone, welcome to our video on one of the most crucial and frequently performed investigation in medicine, the complete blood count. This comprehensive guide will help you to understand every essential parameter of CBC. Today we are going to look at the real patient CBC, learn what all those numbers and term means, and by the end of this video, we will even try to diagnose it ourselves. So let's get started. CBC is the basic blood test that measures three major blood components: the RBC, WBC, and platelets. In whole blood, we have cells as well as plasma. 45% of the volume is shared by the cells and about 55% by the plasma. When we take sample of the blood in tube, then centrifuge it, and in the sample you will see 55% is the plasma and 45% are cells. And in this 45%, major portion is shared by RBCs, about 98%. And then you see a white line in the sample. This is the buffy coat layer, which include leukocytes and platelets, which account for less than 1% of the whole blood. So the major portion is of erythrocytes. So let's start with the red blood cells. Think of them as the taxis carrying oxygen from our lungs to every tissue in our body. In the RBC section, we will discuss two groups of parameters. First, the core RBC parameters, which include the hemoglobin, hematocrit, and RBC count. Next, we will discuss the RBC indices, where core parameters tell us whether anemia or polycythemia is present, and indices help us to determine the cause of that anemia, such as iron deficiency or vitamin B12 and folate deficiency, and also guide us toward the specific type of anemia. In the core RBC parameter, we first discuss the RBC count. The normal RBC count in case of men is 4.6 to 6.2 million per microliter, and in case of female, it is 4.2 to 5.4 million. Low RBC count can lead to anemia, which means the blood has a reduced oxygen carrying capacity. Low RBC count can result from reduced production of RBC, that is due to bone marrow defects, nutritional deficiencies like iron, B12, folate, zinc, cobalt, protein, or low hormones such as thyroid or erythropoietin, or from increased loss, that is hemolysis or blood loss. On the other hand, polycythemia refers to an abnormally high RBC count, often around 8 to 11 million per microliter. Remember, both extremes are harmful. When RBCs are low, the tissues don't receive enough oxygen. When RBCs are excessively high, the blood becomes more viscous, which slows circulation and increases the tendency for clot formation. Physiological polycythemia is commonly seen in people living at high altitudes. Because the oxygen content in the air is low, the body senses relative hypoxia and responds by increasing RBC production. More RBCs mean more hemoglobin available to carry oxygen, which helps maintain normal oxygen delivery. That's why people at high altitude often have higher RBC counts without showing symptoms of hypoxia. Pathological polycythemia occurs when the body increases RBC production in response to chronic or persistent hypoxia. This is seen in COPD and emphysema, where diseased lungs cannot adequately oxygenate blood. In cyanotic congenital heart diseases, where deoxygenated blood mixes with arterial blood, and in carbon monoxide poisoning, where CO binds hemoglobin with much higher affinity than oxygen, reducing oxygen delivery. It can also occur after repeated mild blood loss, which stimulates erythropoiesis, or due to primary bone marrow disorders that overproduce RBCs. Now our next parameter is hemoglobin. These are the normal values of hemoglobin in case of infants, males and females. Again, at birth the hemoglobin is high. Reason behind is also hypoxia. As we know, in uterus, the babies are under hypoxia. As in fetal circulation, the oxygenated blood mixed with deoxygenated blood through the structure like ductus venosus and ductus arteriosus and all that. After 3 months, as babies start breathing, gradually hemoglobin start to reduce, and after 1 year it becomes 17 or earlier. At 6 months, the hemoglobin become normal. The next parameter is hematocrit, which is also known as the packed cell volume. Hematocrit basically a measurement of how many RBCs you have in your blood. Suppose in this sample, the 55% portion is of plasma and erythrocyte contribute about 45% and buffy coat, which contain the WBC and platelets, contribute only less than 1%. So this 45% represent the hematocrit or PCV. Hematocrit is simply the percentage of blood volume occupied by red blood cells. In other words, it tells us how much of your blood is made up of RBCs. As leukocytes are hardly 4,000 to 11,000 and platelets are 1.5 to 4.5 lakh, and on other hand, erythrocytes are 46 to 55 lakhs, so the major portion of packed cell volume is of RBCs. So if WBC count is reduced, it not affect the PCV including platelet, as their contribution is very small. So hematocrit is affected because of RBCs. More the RBCs, higher the hematocrit, and fewer the RBCs, lower the hematocrit. So in case of anemia, the RBCs count is drop, the hematocrit is also dropped. And in polycythemia, the RBCs count is high, the hematocrit is also rise. As we said, the RBCs count directly affect the packed cell volume. But remember, this hematocrit is also affected by plasma volume. So let's understand this from the formula to calculate packed cell volume. The formula to calculate the packed cell volume is the length of red blood cells column upon the total length of blood sample into 100. Suppose the length of the column, which consists of RBCs, is 4.5 and total length is 10. So the PCV comes up to be 45%, which is normal. Suppose RBCs stay the same, but plasma volume decreases. For example, in dehydration, in alcohol use, as alcohol use also produce dehydration and also with the use of diuretic. And now the total length of the column is decreased to 9, but RBC's column remain the same. Now in this case, the PCV is increased even though the actual number of RBCs did not increase. So that's why we always interpret hematocrit together with hemoglobin and RBCs count to know whether the change is due to the actual RBCs loss or just a change in plasma volume. So in above case, the RBCs remain the same, the hematocrit increase, and hemoglobin is also increased. The actual amount of hemoglobin in the body doesn't increase, but because plasma is reduced, the measured hemoglobin concentration appear high. The RBCs may be slightly increase, mild rise, because the blood sample is more concentrated. But physiologically, you didn't produce extra RBC. So PCV is the measurement of how concentrated the blood is with the RBCs. High PCV, the blood is RBC concentrated, either more RBCs or less plasma. And low PCV, the blood is diluted, either few RBCs or more plasma. So now let's understand the relationship of hemoglobin, RBCs and hematocrit with examples. Suppose RBCs drops from 5 million to 3 million. So hemoglobin is also decreased because fewer RBCs carry less total hemoglobin. Hematocrit is also decreased because RBC's layer becomes smaller. This happens in anemia. Suppose RBCs is increased from 5 million to 7 million. So hemoglobin and hematocrit is also increased. This happens in polycythemia. Suppose in dehydration, plasma decreased but RBCs stay the same. So in this case, the RBCs count is the same, the hemoglobin concentration is appear high and hematocrit is also appear high. Hematocrit and hemoglobin goes high even though RBC's number is unchanged. Now suppose in case of iron deficiency anemia and in some chronic disease, the hemoglobin count decrease but RBCs are present in normal number. But in each RBCs, the hemoglobin content decrease. So in this case, the hemoglobin is reduced, the RBCs count is normal. The hematocrit is also low because in iron deficiency anemia, RBCs become smaller and take up less space in the blood. Now, if someone is anemic, that is low hemoglobin, the next question is why and what is the cause behind? This is where the RBC indices come in and they tell us about the size and color of the RBCs. Suppose this is the normal RBCs and the average volume of one RBC is around 80 to 100 femtoliter. And as we all know, the RBCs are enucleated and it mainly contain hemoglobin. The average amount of hemoglobin in one RBC is 27 to 32 picogram per cell. Now we have mass of hemoglobin in one RBC and we also have the volume of that RBCs. Now we can calculate the concentration of hemoglobin in one RBC. As we all know, the concentration is the mass upon volume. So let's use simple number to understand this. Imagine mass is 30 picogram and volume of RBCs is 90 femtoliter. So the concentration of hemoglobin in one RBC comes out to be 33. So this average volume of the RBCs, which is 80 to 100 femtoliter, represent the mean corpuscular volume, that is the size of RBC. And the amount of hemoglobin in one RBCs, that is 27 to 32 picogram, represent the mean corpuscular hemoglobin. And the concentration of the hemoglobin in one RBCs represent the mean corpuscular hemoglobin concentration. So the low MCV means the size of RBCs is smaller, that is microcytic, and high MCV means the large size of RBCs, that is macrocytic. And the normal MCV means the normal size of RBCs, that is normocytic. And similarly, low MCHC means the concentration of hemoglobin in RBCs is low. When the concentration of hemoglobin in the cells is low, the cell look pale, that is hypochromic. And if the concentration of hemoglobin is normal, it is denoted as normochromic. And if the MCHC is high, the RBC is hyperchromic. But this is uncommon, and when it does occur, it usually indicates conditions where RBCs become smaller, dehydrated, or lose their normal biconcave shape, causing hemoglobin to appear more concentrated, for example, in hereditary spherocytosis. These are the different stages of erythropoiesis. During erythropoiesis, RBCs pass through multiple developmental stages. So a small degree of size variation in the bloodstream is normal. However, In many diseases, RBCs may become unusually small or unusually large. So when the RBC's population has a wide range of size, some small size and some normal size and some large size, this increased size variation is captured by the RDW, red cell distribution width. So in simple words, the RDW tells us how much the different size of RBCs present in bloodstream. Its normal range is 12 to 15%. So if RDW is low, most of the cells are of same size or less difference in variation of size. And high RDW means some RBCs are of smaller size and some are of larger size. Now pay attention to this point. In advanced iron deficiency anemia, most RBCs become uniformly microcytic, that is, of small size. And in advanced B12 or folate deficiency, most RBCs become uniformly macrocytic, that is, of large size. Because the cells are all similarly small or all similarly large, the RDW may be normal or low in these late stages. But in the early phase of both conditions, the picture is mixed. Most RBCs are still normal in size, but newly produced cells begin to show abnormalities. That is, smaller cells in early iron deficiency and larger cells in early megaloblastic anemia. This mixture of normal plus abnormal cells increases size variation. So the RDW becomes high in early stage. But in late stage, all the cells become small or larger. Hence the RDW is decreased or normal. So RDW also gives us a clue about the duration of anemia. A high RDW usually indicates a recent or evolving anemia, where normal and abnormal cells coexist. A low or normal RDW suggests a long-standing anemia, where most cells have become uniformly small or uniformly large. And also, when we begin treatment in chronic anemia, the bone marrow starts producing normal-sized RBCs again. These new normal cells mix with the older abnormal ones, thus again increasing the size variation. As a result, RDW rises during recovery. So let's discuss some high-yield anemia patterns. If MCV is low, MCHC is low, and the RDW is high. So the question is, which kind of pattern is this? And what is the common cause of it? An important trick for interpreting RBC indices. Instead of saying MCV is low or MCHC is low, think in plain terms. Read as size of the RBC is low, the concentration of hemoglobin in cells is low, and variation of size is high. So in this case, as the size of the RBC is low, so cells are microcytic. And as hemoglobin concentration is also low, so this pattern is microcytic hypochromic. And the common causes iron deficiency anemia and thalassemia. As hemoglobin is made up of heme and globin, where heme is the iron, so if iron is low, the hemoglobin production slow down. Think of RBC is like balloon, and hemoglobin is the air that fill the balloon.
And if there is less air, the balloon does not expand fully and stays smaller than normal. That's why there is small size of RBC in case of iron deficiency. Next question. If MCV is high, MCHC is normal, and RDW is high, so what kind of pattern and what is the cause of it? As the size of RBC is high, so cells are macrocytic,
And as the concentration of hemoglobin is normal, so the pattern is macrocytic normochromic. The most common cause are the vitamin B12 or folic acid deficiency, chronic alcoholics, and in case of liver disease. Now, interestingly, can somebody tell us what happened to the hematocrit in iron deficiency anemia and vitamin B12 and folic acid deficiency anemia? So let me explain. As the size of RBCs decreased in case of iron deficiency anemia, now the cell occupy less volume. So hematocrit is decreased in case of iron deficiency anemia. But in case of macrocytic anemia, now listen carefully, here the hematocrit is also decreased because in macrocytic anemia, the production of RBC is decreased. As vitamin B12 and folate are essential for DNA synthesis in the bone marrow, and when they are deficient, RBC production slows down and ultimately decreases hematocrit. Beside large size RBCs. And the last question is, if the MCV is normal, MCHC is normal, and RDW is also normal or low. As the size is normal, so this is normocytic. And also the concentration of hemoglobin is also normal. So the pattern is normocytic, normochromic. And its cause include anemia of chronic disease, acute blood loss, and renal failure. The next up, the white blood cell, the body defense force. The total WBC count is important, but the real story is in the differential count. The normal total WBC count is 4,000 to 11,000 cells per microliter. And this is the normal differential leukocyte count. Neutrophils are the first responder to the bacterial infections. Increased neutrophil count often seen in acute bacterial infection. The lymphocyte, they handle the viral infection or chronic infection and create long-term immunity by making antibodies. Monocyte, they are the cleanup crew. They phagocytose debris and increase monocyte count often seen in chronic infections like TB. The eosinophils are the allergy and parasite specialist. High level of eosinophils seen in allergy conditions, asthma, and parasitic worm infection. Basophils, they release histamine and heparin, often high in case of rare allergic reaction. Now finally we have platelets. These are tiny cell fragments that are essential for forming blood clot to stop bleeding. The normal platelet count is between 1.5 to 4.5 lakh cell per microliter. Thrombocytosis refers to an elevated platelet count, typically above 5 lakh per microliter. Most often, it's a reactive response, seen after bleeding, surgery, infections, or in iron deficiency anemia. So whenever you see a high platelet count, always check the hemoglobin as well. It can also occur after splenectomy, during pregnancy, or as part of a primary bone marrow disorder. Thrombocytopenia refers to a low platelet count, clinically significant below 1 lakh, and theoretically we can say below 1.5 lakh per microliter. The most common cause is viral infections such as dengue. Other important causes include liver disease, hypersplenism, where the spleen sequesters platelets, bone marrow failure, and immune-mediated conditions like ITP and TTP. Now, this is important. If platelet count is low, it can be because of increased destruction. For example, in case of dengue fever, because of antibodies, TTP, or there is decreased production. For example, in bone marrow failure or aplastic anemia. To tell that the low platelet count is because of destruction or less formation, we use the MPV value, that is, mean platelet volume. MPV tells us the average size of your platelets. Remember, the fresh platelets are of large size. So if MPV is more, that means the more fresh platelets are there in the circulation. And fresh platelets are only there if bone marrow has no problem. That means if MPV is high, the reason behind is the destruction of platelets. And if there is bone marrow failure, the MPV is less. That is, less fresh platelets in the circulation. This simple parameter helps us avoid unnecessary invasive tests like bone marrow aspiration. The normal value of MPV is 7.5 to 11.5 femtoliters. Now, in the comments, tell me your diagnosis based on this report. Describe the pattern, the probable cause, and whether you think the condition is acute or chronic. In the next video, we'll continue from here and learn anemias and how to differentiate between different causes. For example, if the anemia is macrocytic specifically, how to tell whether it's due to vitamin B12 or folate deficiency.